Snapping hip is a condition in which you feel a snapping sensation or hear a popping sound in your hip when you walk, get up from a chair, or swing your leg around. The snapping sensation occurs when a muscle or tendon moves over a bony protrusion in your hip. Although snapping hip is usually painless and harmless, the sensation can be annoying. In some cases, snapping hip leads to bursitis, a painful swelling of the fluid-filled sacs that cushion the hip joint. Snapping hip syndrome is thought to affect up to 5% of the population, with a higher prevalence in individuals between 15 and 40. It is thought to occur more frequently in females than men, with external snapping hip syndrome being the most common origin. The nature of this condition is typically an overuse injury with a higher occurrence in activities that involve repetitive hip flexion and extension, such as dance, soccer, gymnastics, and running. The hip is a ball and socket joint, formed where the rounded end of the femur fits into a cup-shaped socket called the acetabulum in the pelvis. The acetabulum is ridged by a strong fibrocartilage called the labrum that creates a tight seal and helps provide stability to the joint. Encasing the hip are ligaments that surround the joint and hold it together. Over the ligaments are tendons that attach muscles in the buttocks, thighs, and pelvis to the bones. These muscles control hip movement. Your doctor will first determine the exact cause of the snapping by discussing your medical history and symptoms and conducting a physical examination. He or she may ask you where it hurts, what kind of activities bring on the snapping, whether you can demonstrate the snapping, or whether you have experienced any injury in the hip area. Patients reporting anterior groin pain usually note that the pain is dull or aching in nature and is exacerbated by extension of the flexed, abducted, and externally rotated hip. The pain and snapping may subside with decreased activity and rest. The duration of symptoms at presentation more commonly is several months or years rather than days or weeks. The location may be described as lateral, indicating the iliotibial band or gluteus maximus, or anterior and deep in the groin, indicating the iliopsoas tendon. A version of the FABER test can be used to differentiate between internal or external generated snapping hip. FABER standing for flexion, abduction, external rotation. By placing the affected hip into the FABER and passively moving the hip into an extended, abducted, and internally rotated position, an audible snap may be heard. You may also be asked to stand and move your hip in various directions to reproduce the snapping. Your doctor may even be able to feel the tendon moving as you bend or extend your hip. Individuals typically present with reports of an audible snap or click in the hip, which may be either painless or painful. Other tests include the Ober test and the Brignell et al. Test. Conservative management is the first and most preferred treatment approach and often involves methods used to treat common forms of tendinitis. Commonly consists of rest, ice, non-steroidal and anti-inflammatory medication, corticosteroid or lidocaine injections, and physical therapy. A surgical intervention is only recommended as a last resort, only when conservative treatment has not improved symptoms. The main purpose is to lengthen or relax the tight tendon or ligament to eliminate the snapping and also to correct any associated or contributing pathologies, which are very common in SHS. There continues to be some controversy over which type of surgical procedure is best for each of the classifications of SHS. However, researchers do agree that if surgical intervention is necessary, arthroscopic surgery allows for better results and less complications when compared to traditional open surgery. While each person will recover at a different rate, doctors expect patients to return to work between 6 and 8 weeks for office jobs and 3 to 6 months for physically demanding labor. Return to work should also be phased: 3 half days in the first week, 2 full days in the second week, and 5 half days in the third week, and full time by week 4. Your doctor may prescribe exercises to stretch and strengthen the musculature surrounding the hip. Guidance from physical therapists may also be recommended. The iliotibial band stretch is a stretch that obviously stretches the iliotibial band. Stand next to a wall for support. Cross the leg that is closest to the wall behind your other leg. Lean your hip forward to the wall until you feel a stretch on the outside of your hip. Hold the stretch for 30 seconds. Repeat on the opposite side. Perform 2 to 3 sets of 4 repetitions on each side. The piriformis stretch is another option. Lie on your back with bent knees, feet flat on the floor. Cross the foot of the affected hip over the opposite knee and clasp your hands behind your thigh. Pull your thigh toward you until you feel the stretch in your hip and buttocks. Hold the stretch for 30 seconds. Repeat on the opposite side. Perform 2 to 3 sets of 4 repetitions on each side. The primary goal for prevention of snapping hip syndrome is maintenance of good flexibility and strength in the hip and pelvis. I think what I found most interesting about this project was that when I started telling people oh yeah, my final for athletic training, whatever, and describing it to them, I realized how many people I actually know who have snapping hip syndrome, and how that's cool that athletic training comes up in my real life, and also how many people self-diagnose themselves when you tell them what snapping hip syndrome is. The sacroiliac joint is a large joint that connects the lower part of the spine to the pelvis. It is a primary source of pain for 10% to 26% of patients with lower back pain. When evaluating a patient who presents with lower back pain, doctors take a detailed history and do a thorough physical examination. They do plain X-rays, MRIs, or CT scans to rule out other causes of lower back pain. Imaging studies are not reliable tests to diagnose SI joint pain because it may look normal or similar to the SI joint on the painless side. Injection of an anesthetic into the painful SI joint is a more reliable test. If the injection does not give any relief, SI joint pain can be ruled out. People with sacroiliac joint dysfunction tend to complain about lower back pain and aggravation with activities such as climbing stairs, getting up from a chair, or getting out of a car. Other common patient complaints are buttocks pain, pain radiating to the leg, hip pain, groin pain, urinary frequency, iliac crest pain, numbness or prickling or tingling, increased pain with stair climbing, increased pain with sustained positions, such as walking, sitting, or lying. One of the most common causes of sacroiliac joint dysfunction is an injury. The injury can come from a direct fall on the buttocks, a motor vehicle accident, or sports-related trauma. The force from these injuries can strain the ligaments around the joint. Tearing these ligaments can lead to hypermobility in the joint. This excess motion and lack of stability is thought to be the main cause behind sacroiliac joint dysfunction. Pregnancy may also be a factor in the development of SI joint pain. Women secrete the relaxin hormone during pregnancy. This hormone allows connective tissue in the body to relax. The relaxation is needed so that the pelvis can stretch enough to allow the baby to pass during labor. This stretch may affect the SI joint, causing them to become hypermobile. The more pregnancies a woman has, the more chances she has of developing SI joint pain. Leg length discrepancies may also play a role in sacroiliac joint dysfunction. If a person has one leg that is shorter than the other, the abnormal alignment may end up causing SI joint pain or malalignment issues. In the acute stage, which occurs 1 to 4 weeks after the injury, abnormal motion of the joint can be seen. This may result in pain or muscle spasms. During the subacute stage, which occurs 1 to 3 months after injury, further disruption of the SI joint mobility can occur. This may lead to persistent pain and a change in the way that we usually walk, known as gait disturbance. The chronic or final stage occurs after 3 months. This is characterized by degenerative changes in the joint, which may be difficult to correct. This could ultimately lead to disability. The demographic that this injury typically affects are predominantly in women. During pregnancy, up to 80% of women experience pain from the SI joint. Conservative management of SI joint dysfunction is the preferred treatment. This starts with physical therapy. In therapy, muscle length and flexibility are restored to shortened muscles. Strengthening the core muscles or muscles supporting the spine, as well as stabilization of the SI joint, are achieved. Joint mobilization or manipulation to restore normal joint movement is also utilized. The therapist will focus on gait and posture retraining to prevent reoccurrence of instability or pain. Sometimes a supportive SI joint belt is used to stabilize the joint. In addition to therapy, medication such as anti-inflammatories are used. A cortisone injection can be performed if pain persists despite the therapy or medications. If all fails, prolotherapy, a series of injections into the surrounding ligaments to stimulate the body to repair and regenerate itself, is attempted. In very rare occasions, surgical fusion of the SI joint can be performed for pain relief, but most patients respond to non-surgical management. With the posterior approach, weight bearing is usually full and immediate right after surgery. If you have a lateral approach, then weight bearing is usually limited from anywhere to 6 to 12 weeks, depending on your surgeon's preference and experience. On average, successful sacroiliac joint fusions with the posterior approach return to work in about a 3-month period. The sacroiliac joints are essentially non-weight bearing joints that function to absorb forces from various directions. The common onset of dysfunction is during trunk flexion, when a person is standing without adequate support of the anterior pelvis. The anterior shift of the weight of the upper trunk causes innominates to rotate anteriorly and downward and become fixed on the sacrum. Movement downward of the acetibula in relationship to the sacroiliac joint not only results in biochemical changes, but also causes the legs to appear longer than they actually are. Something we found interesting about sacroiliac joint dysfunction was that another one of the special tests was an injection to test for dysfunction. The primary stabilizers of the SI joint are ligaments of the pelvis. The secondary stabilizers are the muscles which surround the pelvis, the hip, and the spine. Strengthening these muscles can provide stability to the SI joint, as we cannot strengthen the underlying ligaments.